Hi, everyone. My name is Eleanor Scimone, and I'm the Massachusetts General Hospital Myhre Syndrome Clinical Research Assistant. And today I'll be presenting on brain and spine imaging in 40 patients seen in the MGH Myhre Syndrome Clinic. So because little is known about the central nervous system within Myhre syndrome, the purpose of this study is to review brain and spine imaging among 40 patients with Myhre syndrome who have been seen in the MGH Myhre Syndrome Clinic. We also want to determine the frequency of MRI and CT imaging in the head, neck, and spine within Myhre syndrome, specifically focusing on the number of brain MRI, MRA, head CT, CTA, chest CT, or CTA of the aorta, and spine MRI, MRA. We also want to characterize the abnormalities seen within the central nervous system with Myhre syndrome, and more specifically, we want to learn if these abnormalities are progressive, remain the same over time, congenital, which means that they are present at birth, or acquired, meaning that they develop after birth. So once we have the answers to these questions and other similar ones, we can then dive deeper to evaluate whether baseline brain and spine imaging should be part of care or only on a symptomatic basis as it is now. We also hope to eventually analyze different factors that might impact the occurrence of observed abnormalities. This includes SMAD4 variant, demographic features, medical factors, and many other variables as well. Lastly, we hope to learn whether or not these abnormalities can be attributed to dysregulation of the TGF-beta signaling pathway that is associated with SMAD4. Before we continue along, I just want to provide some useful definitions. So MRI stands for magnetic resonance imaging, and this technique uses magnet to help image the body and create pictures of different parts of your body. Next is MRA, magnetic resonance angiography, which uses a similar technique as MRI to image blood vessels and blood flow. CT stands for computed tomography and involves the use of X-rays from a tunnel-like machine. This is used to produce images of the inside of the body. CTA stands for computed tomography angiography and often uses a temporary dye to create pictures of blood vessels and tissue using X-rays. MRI scans often produce better pictures, but they take longer than CT scans. So in order to answer the questions from the previous slide that talks about the purposes of this study, I've been working with a large team of specialists who you can see on the screen here. All of these doctors are part of the MGH Myhre Syndrome Clinic team, meaning that they are familiar with Myhre syndrome and have actually been a part of care and have been involved with this brain and spine imaging project. We started this project by identifying the types of brain and spine imaging done in our cohort of 40, as well as their frequencies. Once we had these numbers, checked them over multiple times, and had many discussions about them, we then began a systematic review of each image. This systematic review is led by myself, the research assistant, Dr. Lin, a geneticist, and one of the co-directors of the MGH Myhre Syndrome Clinic, as well as two radiologists, Dr. Karen Book and Dr. Otto Rappolino. The other doctors listed below on the screen have also vastly contributed to this project and have played very important roles as we learn more about this complex topic. Something important to keep in mind as I continue along in this presentation is that this study is still ongoing. So we're actually still collecting these images as well as reviewing them. So a lot of the numbers and data shared in this presentation, we do expect to see some increase. These numbers could increase by just 1 or 2 or by many more than that. So before we get into the actual results, I just wanted to share some more information about the 40 patients that we have seen, as these demographics could be important for interpreting the data later on when this study is finished. As you can see in table 1 on the left, 43% of the 40 patients are male and 57% are female. 43% of these patients are between the ages of 0 and 7, while 57% of these patients are ages 8 and up. As you can see, as of January of this year, the age range of these patients is 3 to 51 years. And then to better understand the age distribution, the median age of this cohort is 8, and the mean age is 11.4 years. In table 2 on the right, you can see the distribution of SMAD4 pathogenic variants found within this cohort. The highest frequency is the isoleucine to valine change at residue 500. No methionine variants were recorded in this cohort. For more specifics about this cohort in a slightly larger group, Dr. Angela Lin, one of the co-directors of the MGH Myhre Syndrome Clinic, has a video that is part of the series that will be released soon. So now to get into the actual results. Within this cohort of 40 people, the following brain and spine imaging frequencies were seen. For MRI, MRA of the brain, 25 out of 40, or 63% of patients had these studies performed. For CT of the brain, 6 out of 40, or 15%. For MRI, MRA of the spine, 13 out of 40, or about 1/3 had images. And for CT of the chest, or CT of the aorta, 27 out of 40, or 68% had these images done. So now to talk about results from the brain MRI scans. So for the next few slides, it's really important to look at some of these frequencies in the context of those who have had imaging done. Thus, I have provided a reminder on some of the slides, as you can see here. So again, 25 out of 40 of these patients have had brain MRIs. In 36%, or 9 out of 25 of these patients, white matter hyperintensities have been seen. These spots within the brain tissue that are apparent on MRI have been seen in many different places throughout the brain. Our team is currently further investigating what these hyperintensities mean and how they are formed and when they are formed. As of right now, we are not seeing any correlation regarding the location of these spots to the SMAD4 variant or to intellectual disability. We're also not seeing any pattern between their presence or absence of these spots when evaluated with SMAD4 variant or intellectual disability. From these images, we have also seen that 10% of the entire cohort have vascular abnormalities. So the visual system within humans describes how we see and understand what we are seeing. This is part of the central nervous system and is very intricate. So to simplify it, just think of the eye as a globe or a ball with a line coming from the back of it. This line is called the optic nerve. So within these patients, we are seeing posterior globe flattening, so the back of the eye is flattening, and protrusion of the optic nerve, shown in the picture on the right. These can be seen from brain MRIs. Previously, this had been classified as papilledema or drusen, but our team felt that the term posterior globe flattening and protrusion of the optic nerve better described what we see. This has been noted in 7 out of 15 patients, and these 15 patients include those whose brain MRI images were stored within the MGH system and/or had mention of this from an ophthalmologist at home. So while 25 patients have had brain MRIs, part of our ongoing study is collecting and then reviewing the images that were done at outside hospitals. However, we're able to use 25 for the denominator for the hyperintensities, as they're often noted by home care teams. And then this picture shows white matter hyperintensities from 3 different patients. And as mentioned on the previous slide, as you can see, they're not in the same place for every patient. So now to talk about results from the brain CT. So similar to brain MRIs, not all of the brain CTs from this cohort were performed at MGH. So when this first set of data was collected, we did not have all the images to view. However, from these scans, we have seen that at least 2 patients exhibit inner ear anomalies and at least 2 patients have a thick calvarium. As you can see here in the picture, the skull appears thick, and upon measuring it and comparing it to calvarium thickness to a general population, we're able to conclude that it is indeed thick. So now to talk about chest CT results. So in this cohort, there are 27 patients with a chest CT or CT of the aorta. This number will increase over time, considering that most patients do not get these scans until they are 7, and 43% of this cohort is between the ages of 0 and 7. These scans are highly valuable for this project because many of them allow us to have different views of the spine as well. From these scans, we have seen enostoses and exostoses in at least 10 out of 40, or 25% of patients. These can essentially be described as excess bone growth or bone islands, and they sound scary, but we feel as though these demonstrate the idea of gain of function that is associated with Myhre syndrome. Because we're able to see views on the spine of some of these scans, we have also noted 14 patients with a sacralized L5, which is essentially fusion between parts of the bottom of the spine. Various minor skeletal anomalies have also been detected, but there will be more on that as the study progresses. Now to talk about results from the spine MRI. So lastly, 13 patients in this cohort have had a spine MRI. Transitional tethered cord has been noted in 4 patients out of 40, and all 4 of these patients have had surgery. However, what is important to note is that this number 4, once it is put over the number of patients who have been imaged, so 13, it then becomes that tethered cord has been seen in 30% of imaged patients. Our team has concluded that in order to further investigate the topic of tethered cord and Myhre syndrome, when reviewing these images, we look for about 5 different variables, including symptoms as well as radiographic findings. 2 of these variables include a filar lipoma, which is typically a benign lump of tissue at the end of the spinal cord, and a low-lying conus. These have been seen in 2 patients and 1 patient respectively. However, as we review more of the images from outside hospitals, we do anticipate these numbers to increase slightly. Lastly, here are some additional findings that have surfaced from our systematic review of the images. These were seen from either chest CTs or head CTs. We do anticipate these numbers to increase as we continue to review the images that we do not have. So now I just want to summarize the study and what we have learned so far, reinforcing again that this study is still ongoing, so we do expect some of these numbers to change. Additionally, this has also allowed us to dig deep into many different topics in Myhre syndrome that we hope to explore even further in the near future. One of the key takeaways is that due to inconsistent brain and spine imaging in Myhre syndrome, the true frequency of many features is unknown. We also know that Myhre syndrome causes both congenital and acquired anomalies of the central nervous system, but many of these require ongoing clinical and radiographic analysis to better understand them. Going forward, as we continue to review this data, we're working towards a better understanding of the white matter hyperintensities and hope to learn if these do correlate with structural and/or functional abnormalities. We also hope to follow patients who have had tethered cord surgery to learn more about its efficacy. And we're also currently further investigating the optic nerve abnormalities and posterior globe flattening within the eye. While we are still collecting and analyzing data, we defer recommending brain and spinal cord imaging as routine surveillance, which I'll talk a little bit more about on the next slide. However, we do encourage prompt spine MRI imaging for patients with symptoms or signs of cord tethering. So to end my presentation, I'm going to discuss some of the pre-submitted questions. So the first question is, what signs should we look out for that there might be issues with the brain? How do we know if the brain is being affected? So as of right now, the signs to look for regarding issues with the brain would be seizures or sudden onset of change in mental status. Because we're still learning about the brain and spine within Myhre, specifically the white matter hyperintensities and what they signify, it is hard to provide guidelines as we're not completely sure how all of these things are correlated. Thus, in order to talk about what signs to look for, that would imply that we understand all of these changes. However, when these issues arise, doctors do truly take them seriously. The next question is, what data has been seen that suggests that we should be paying closer attention to the brain and spine? So after having heard my talk, I'm sure you can understand that as of right now, we do not have a direct correlation between the white matter hyperintensities and various brain issues such as delay or autism. So as we begin to better understand these, then we can be certain as to whether or not we should be paying close attention to the brain. As for the spine, that's a little different as we are focusing on patients with features of tethered cord. However, due to the frequency of tethered cord in those imaged, we are beginning to pay closer attention to tethered cord in Myhre syndrome. Additionally, after reviewing chest CTs, which again provide some views of the spine, we're beginning to see more radiographic findings that when paired with symptoms may correlate to a tethered cord. The next question is tethering of the spinal cord more frequent in those with Myhre? So we do feel as though tethered cord is more common in Myhre, however, not the classic type of tethering that often occurs in other disorders that can be scary to read about. Generally, we are seeing a more mild type, and when looking into these, we are looking for a cluster of 5 or so variables, including symptoms and radiographic images. Do individuals with Myhre syndrome ever have regression? How can we help our kids who have to keep relearning things? So between the Myhre Syndrome Foundation Professional Advisory Board and the 44 patients who have been seen at the MGH Myhre Syndrome Clinic, some of whom are not included in this data set, we have not heard of regression. As far as relearning things, there is unfortunately no single treatment. In general, these patients have varying degrees of cognitive, emotional, and behavioral problems, and individuals with intellectual disability and more than mild autism spectrum disorder will often need constant reminding and relearning. Those who do not fit that category often do not. It is difficult to be more exact as this is all of a spectrum. Will brain and spine imaging become a standard test for people with Myhre? So we are very close to making that recommendation. The ideal way is to determine guidelines by using evidence, and we're almost there. As of right now, it'd be easier to recommend brain imaging over spine, and thus we are very close to making a recommendation for brain MRI. Whether that will include spine imaging as well will depend upon the conclusion of this study. So now to end my presentation, I just wanted to thank you for listening and say thank you to the Myhre Syndrome Foundation for hosting this.